Bienvenidos a todos. Queremos darles un cordial saludo en esta primera sesión de nuestros workshops en el Congreso de la SLED. Vamos a introducir la primera sesión de diabetes y un módulo que tuve el agrado de coordinar junto con Ethel Corner. Esperemos que lo disfruten. Para nosotros también ha sido muy enriquecedor trabajar con nuestros colegas de Latinoamérica y empezaremos con nuestra charla magistral. Ethel.
Bueno, bienvenidos a la primera workshop en diabetes SLEP. Tenemos una excelente conferencista para dar nuestra charla magistral. It is my honor to introduce Professor Linda Di Meglio to give the first talk and the inaugural talk of the first workshop in diabetes that SLEP organizes. Professor Di Meglio is the Chief of the Division of Pediatric Endocrinology and Diabetology at the Department of Pediatrics at the Riley Hospital for Children in Indianapolis. She has a long career in research, and she's currently a member of the ISPAD guidelines for editorial board guidelines. One of the main research that Professor Di Meglio has developed is in the prevention of type 1 diabetes, and she is going to give us this talk entitled Prevention of Type 1 Diabetes, Looking Back and Inching Forward. O sea, el título de esta conferencia es Prevención de Diabetes tipo 1, mirando hacia atrás y avanzando un pasito hacia adelante. Professor Di Meglio, thanks again for giving the talk. Thank you.
So hello, and thank you to the organizers for inviting me to speak today on this topic, Prevention in Type 1 Diabetes, a look back and future perspectives. These are my disclosures. So I'd like to take you through in about the next 25 minutes is a talk on type 1 diabetes. We'll start with where we are in treatment and why we need prevention. I'm going to then spend a little bit of time on what we've learned about prevention, ways that we're currently trying to do prevention trials, and then some paradigm shifts that I think will move us forward to more effective prevention therapies. So from where we sit now in 2021, here we can journey back about 100 years to the discovery of insulin in the summer of 1921 by Banting and Best, here shown with one of their dogs. And move forward about 50 years to my childhood, to when clinic testing of urine became available, when glycohemoglobins became available, when more concentrated insulin came out and the first insulin pumps. And then move forward another 50 years to where we are today with a bunch of different devices, newer insulins, continuous glucose monitors are even implantable, a lot of integrated devices and software. And where we are currently in 2021 is we are in an era of multidisciplinary and often technology-driven care. We are giving insulin as analogs and through continuous delivery systems. We are doing advanced glucose monitoring, including continuous glucose monitoring. And we have enhanced education with intensive insulin management. And we now know that much of our focus needs to be on cardiovascular risk factor modification for our patients. And all of this is done to reach glycemic targets in part. And these glycemic targets for children, I show you here with A1C goal from the NICE consortium of less than 6.5% for children, and ADA and ISPAD having a goal of less than 7% or less than 53 millimoles per mole. So with all this technology, all these advancements, and understanding that we need these tight glycemic targets, why do we still need prevention? I'll take you through a few reasons that I believe this is the case. The firstly is that type 1 diabetes is increasing, and from a variety of studies in a variety of settings, we see that if here would be 0, where there is no change in the incidence of diabetes, we see that overall we are seeing about a 3.4% increase per year in the incidence of type 1 diabetes. I just want to take a moment now to speak really briefly about effects of COVID potentially on diabetes incidence, because this is certainly a hot topic. And really the question being, does COVID-19 cause or accelerate diabetes? And I'd like to say from where we sit right now in October of 2021, that to date, population-based reports have not confirmed an initial brief observation of acute disease increases. And rather, data has definitely suggests that people presenting with new onset stage 3 type 1 diabetes and new onset type 2 diabetes have delayed access to care, leading to more severe acute presentations. It is possible that the cytokine storm seen in COVID-19 could injure or stun limited beta cell reserve in people nearing stage 3 or worsen insulin resistance in type 2 and accelerate disease presentation. And it's currently a hot topic of debate as to whether COVID-19 itself infects beta cells. But I think overall it's too soon to know, and we need to wait for good epidemiologic data. But it's possible we will see even more type 1 diabetes as we emerge from this pandemic. The second reason that we need to work to prevent type 1 is that we are definitely failing to achieve those A1C goals I showed you earlier. Now, these data I'm showing are at a time when our A1C goal for children, at least here in the US, was 7.5%, and the A1C goal for adults was over 7. And so if we look at mean hemoglobin A1C by age, we published data from the Type 1 Diabetes Exchange, which was a registry of patients throughout the US, that showed between 2010 and 2012 that we were not, this mean A1C by age, that we were not meeting those goals. And we were very surprised when a few years later, we looked again, this now with an increase in use of technology in this population, and we saw actually even higher hemoglobin A1Cs across time. So we need to work to prevent type 1 because we're not getting there as far as A1C goals. Another thing that we're not reaching goals on is for severe hypoglycemia. And this is SWEET data on severe hypoglycemia by continent out of SWEET, including data from your area in South America, showing that overall severe hypoglycemia rates are about 1 to 2% per year, meaning that 1 or 2 persons with diabetes per 100 are having hypoglycemia. There are other registry data that actually suggest higher severe hypoglycemia rates. This is data from the German-Austrian group, the US, and the Australian groups, and all of these show a severe hypoglycemia rate of about 5 events per 100 patient years. What's important about these data is 2 things. One is that this is unacceptably high, which is why I'm using these data as a way to say that we need to prevent type 1. But secondly, it's also important to note here that severe hypoglycemia rates do not go up for kids with lower A1Cs. And you see that here with severe hypo across A1C category is very flat. And this also has led us to the knowledge that we can afford, so to speak, to have lower A1C targets in children without risking severe hypo, which was not the case 20 years ago. Reason number 4 is high rates of diabetic ketoacidosis. Here, I'm showing you data from Germany with about 31,000 patients. These are pediatric data, median age 12.7 years, median A1C of about 8%. And you can see the overall admission rate for DKA was about 5 per 100 patient years. So about 1 in 20 children was being admitted for DKA. And here, unlike the severe hypo, you see that there is an increase in likelihood of DKA per 100 patient years in kids who have higher hemoglobin A1Cs. So I'm going to move on to some of what we've learned that allows us to think about preventing type 1. So in order to prevent or cure type 1 diabetes, we first need to know more about how it develops. So when we think about type 1 diabetes progression, we start here on the left with genetic risk. If you have a relative with type 1 diabetes, you have a 15 times greater risk of developing type 1 diabetes than from the general population. So everybody diagnosed with type 1 diabetes has the genes associated with type 1 diabetes. And overall, the general population risk is about 1 in 300. Whereas if you are a family member, you're at 15 times greater risk with a relative risk of 1 in 20. The second stage in the progression of type 1 diabetes, which not everybody with genetic risk will move forward to, is immune activation. Whether this immune activation is due to a defect in the immune system or potentially having wimpy beta cells that are more predisposed to attack is unknown. But of those people with immune activation, most people likely have it shut down, but some will move forward to immune response and development of a single autoantibody. Of the people with a single autoantibody, some will go on to stage 1 of diabetes. And stage 1 of diabetes is defined as the start of type 1 diabetes. People in the first stage of diabetes have 2 or more autoantibodies shown here, along with beta cells that produce insulin that still remain. They have normal blood sugars and have no symptoms of diabetes. We know that once you reach stage 1 of diabetes, you have nearly 100% lifetime risk of going on to develop diabetes. And these data come from multiple sources, including data from Annetta Ziegler's group, shown here, where once people are at stage 1 of diabetes, shown in the green line, with 2 or more islet autoantibodies, their 20-year risk of developing stage 3 or clinical diabetes is approximately nearly 100%. We know that whether or not you have a relative with type 1 diabetes, as in that German cohort, or you come from the general population, as in a Finnish cohort, or in this case, there's a mixed cohort, your likelihood of progression to diabetes over 20 years is very similar. From stage 1, people then move on to stage 2 of diabetes. In stage 2, you again have 2 or more autoantibodies that remain. You have fewer beta cells, but not enough to keep the blood sugar normal. So you have some dysglycemia, and these people have no symptoms. We have now had a recent success in prevention of type 1 diabetes in people who have been treated with a drug called teplizumab, as I will show you on the next slide. And here you see the masthead of the paper showing that teplizumab was able to delay progression from stage 2, so dysglycemia, to stage 3 or clinical type 1 diabetes by a median of 2 years. These data led to breakthrough therapy designation by the FDA for teplizumab in prevention of type 1 diabetes. What we found in the study was that 2 weeks of teplizumab treatment delayed type 1 diabetes in people in stage 2 of diabetes. We found that teplizumab was safe. This was the first trial to show that immune therapy could be used to delay type 1 diabetes. Other trials, as I'll show you, have been done in people with stage 3 to preserve beta cells, but this was the first to show delay. And with further follow-up of these individuals, we know that the delay in median time to diabetes, which was first reported in that New England Journal paper as 2 years, is now over 35 months. And we've also found with further analyses that subgroups of individuals identified by characteristics at screening have particularly robust and durable responses to teplizumab. So we are doing through TrialNet a randomized, multi-center, double-blind, placebo-controlled trial in children and adults 8 years of age, using hydroxychloroquine, which has gotten a lot of press early in the COVID pandemic as a potential treatment for COVID. And although it was not effective for COVID, it has been used as a drug for rheumatoid arthritis and has immunomodulatory effects. Hydroxychloroquine has advantages because it's an oral therapy. And what we're looking at is the ability of hydroxychloroquine to delay or prevent progression from stage 1 on to stage 2 or stage 3. This study is still enrolling. So I'd like to close with a few minutes speaking about paradigm shifts that I think we need to take to make more progress. And I'm always a fan of leaving any meeting, or in this case, a talk, with some action items. In this case, I would like to leave you with some logical next steps where we can explore novel solutions. And so that you can anchor these solutions in your head with an image, I've provided a cartoon character for each of the possible next steps. So the first step is to approach type 1 diabetes as a syndrome. Here I've chosen Syndrome from The Incredibles as my character. The second is to explore the intrinsic role of beta cell and the exocrine pancreas. Here I've chosen Dory, who forgets all the time from Finding Nemo, because I don't want us to forget the beta cell. Third, I'd like to consider population type 1 diabetes screening. And here I've chosen a globe to say that this is worldwide and we need to be able to think about the whole population, because I think otherwise we run the risk of falling victim to the streetlight effect, which is shown here by the man who's looking for his quarter that he dropped, and the policeman coming to help him says, "Did you drop it here where the light is?" And he says, "No, I dropped it 2 blocks down the street." So the policeman says, "Why are you looking for it here?" And he says, "Because the light is better here." And I think in some ways, by just focusing on relatives of people with type 1 and not looking at the whole population, we are focused on where the light is best and where it's easiest to find people to potentially participate in our studies, but not looking at the whole population and not taking advantage of going where the actual population is that we can capture. I'd like us also to rethink trial designs. And here I think of Snoopy as our statistician, and the fact that we love our statisticians and the ways that they can help us rethink things. And it likes us to think about where we've gotten sad and re-examine our failures. So with the first solution of approaching type 1 diabetes as a syndrome, we recognize that there are multiple endotypes of type 1 diabetes now. And I think this is part of why we've failed to cure type 1 diabetes to date, is that we've taken type 1 diabetes as a whole and not looked at differences between and within individuals. And this is one piece of evidence that there are differences in individuals developing type 1 diabetes by age. And this shows that if you look from older here in the green to younger populations, so this is 12 and under, this is 12 to 17 years of age, and this is over 18 years of age. And you look at the likelihood that after the diagnosis of diabetes here, that people continue to have C-peptide of greater than 0.2 millimoles per liter, then you are less likely to continue to make CPEP even 4 years after diagnosis if you are under the age of 12 than if you're over the age of 18. And so if you just did a study and everybody getting the therapy was in the 18 and up group and everybody not getting the therapy was in the 12 and under group, you would assume that that therapy had an effect, even if it had no effect, just simply because of the difference in the two populations that you're looking at. And there's ways to identify endotypes within people with diabetes. This is a very interesting paper that was published in January of 2020, looking at different ways to identify these endotypes. There's a whole bunch of different phenotypes you could look at. You take people and then you sort them out. I always think this is like Harry Potter and the sorting hat. And you sort them into different groups, and you can then look and you can take these groups and you could potentially run trials in different groups based upon the etiology of their diabetes and potential responses. So if you separate the endotypes in trial design, you can then tailor the proposed therapy to the mechanism of beta cell loss or failure for an individual, and select people receiving a therapy based upon the markers of those most likely to respond, whether those are genetic factors, stage of disease markers, or beta cell health markers. Solution number 2 is coming back to Dory. So remembering the beta cell and the exocrine pancreas, I believe firmly we need to continue studies of the exocrine pancreas and consider adding agents to immunomodulatory studies that will improve beta cell health. And so for the last 40 years of research, type 1 diabetes has been labeled as autoimmune, and we've focused on immune constituents. So if each of the size of these circles is reflective of the research activity until recently, there's been huge amounts of research activity around CD8 cells, a lot around regulatory T cells, much work done on autoantibodies, and even some more limited work on B cells. And this is not without reason. This is also very important. But the exocrine pancreas is nearly nowhere to be found. And so what we need to do is remember the beta cell, and because the beta cell is ultimately the thing that these T cells and B cells are targeting to get us to type 1 diabetes. So if we move here to this diagram I showed you earlier, and on the right-hand side, we focus on the beta cell, we can see that there have been some therapies that have been used to try to target the beta cell, and Gleevec, which recently has had some successes. But I believe there's other places we could go here to add other agents that target the beta cell, including agents that target beta cell stress, such as DFMO or TUDCA. There are trials. We've completed a trial now using DFMO. We'll have data that are going to be presented at the Immunology of Diabetes Society meeting next month, suggesting that DFMO is safe in people with recent onset type 1 diabetes and may have some effects on beta cell preservation. And a second study done by Robin Goland at Columbia has looked at TUDCA. There's also ways to support the beta cells, including proton pump inhibitors, verapamil, which is being studied in a JDRF-funded study here in the US, as well as in Europe, and other incretin-based agents. The third solution is to consider population-based screening. So population-level screening is now feasible. We do it for other diseases, and it's possible in type 1 diabetes. There have been multiple studies that have shown that you can do it at a population level. Efficiencies, however, needed to make it cost-effective for clinical practice. What we know from what's been done so far is that targeted screening can prevent decay at diagnosis, and that parental stress associated with notification of a positive test is reduced with time and education. I firmly believe that population-based screening can empower clinicians, people who have diabetes-related autoantibodies, and families, and in part, it gives them an opportunity to participate in research to try to prevent or delay type 1, and also prompts closer monitoring and management of type 1 diabetes prior to clinical disease that can allow people to ease into the diagnosis more easily. Future directions for screening as we looked into the future, well, one is that screening for genetic risk could be done for all newborns as a part of newborn screening programs. Antibody testing could be done in pediatrician offices as part of preventative care, or through home-based testing where people could be sent kits. If we do it through a pediatrician office, it could be linked to other regular screenings, for example, screening for lipids. The fourth solution is to rethink trial design. Here, I think we need to think about dose ranging studies with new agents. This is something we did with our DFMO trial, and we tried to choose the best dose before we moved into a fully powered trial. We also need to conduct more pilot studies before launching into fully powered trials. And once we do a pilot trial, it's really important that we replicate those results prior to moving ahead. We also need to consider new study designs. And one of these things is that we need to incorporate measures of response early in the course of therapy and then change the therapy as needed. I think we need to change the one therapy and done mindset, think about combination therapies, adding therapies, so adjunctive therapies, doing sequential therapies, so treating with one drug and then a second drug, and then thinking, as I mentioned earlier, about longer term therapy. The fifth solution is I think we need to think about where we got SAD and re-examine our failures to appreciate potential future successes. So these are data from the oral insulin study that TrialNet published in January of 2017. And the take-home message of this trial was that oral insulin was not effective in people with the normal phase, first phase insulin response in preventing progression from multiple autoantibody positivity. One of those antibodies had to be insulin to diabetes. But however, we look at the group here that had impaired first phase insulin response, that had presumably the most active immune disease. Here we did see a delay, a significant delay of many months in diagnosis of diabetes. And so, you know, this is a group where presumably there was benefit. And it was studies like this, plus questions about the dose that we provided of oral insulin have led to oral insulin still being looked at in prevention therapies, in part because it's also generally regarded as safe drug. So as I close, certainly our journey to a cure for type 1 diabetes and to prevention of type 1 diabetes has not been this straight and kind of sunny road, but more like this, where we've made progress and we're working our way up the hill, but we've had multiple turns and it's going to take a lot of effort to get there. And I always like to close with this slide, which says insulin is not a cure for diabetes, but keeps people alive until we find one. And I believe strongly we all need to continue to fight the good fight and do what we need to do to get to prevention and to cure for our patients who live with this disease. So with this, I will close with a thank you, and I welcome your questions. And I'd like to thank in particular my collaborators within the Center for Diabetes and Metabolic Disease, are the group that I've worked with in the Type 1 Diabetes Exchange Registry, my colleagues within TrialNet, the study team that helped us with the DFMO trial, the funders who have supported our work, and our research staff. And with that, I'll close.
Thank you, Linda, for this excellent talk. And now we have some time to answer the questions from the audience.
Gracias, Linda. Una excelente conferencia. Ya que no hay preguntas desde la audiencia, voy a hacer algunas preguntas, primero en castellano y después se las voy a traducir al profesor Demetrio en inglés. Mi primera pregunta es sobre la inclusión de niños en los trials de prevención, que desgraciadamente pocos estudios incluyen niños pequeños y tenemos muchos debuts de niños y adolescentes de baja edad. Y a mí en forma especial me preocupa que esto va a terminar llevando a que los papás usen estos medicamentos en una manera off-label. Así que eso vamos a ver. Linda, I wanted to ask you about your thoughts about the inclusion of very young children in the trials. Since we don't have data about prevention in young children, I'm afraid that parents will use off-label these drugs in a desperate way. So how do you see the future in this regard?
I think that it's important that we include children of all ages in trials. So I had shown some data suggesting that there were differences by age in populations of that are studied, at least as far as beta cell continued beta cell function after diagnosis, clinical diagnosis of type 1. I do agree that it takes longer to get studies even into any children, much less young children, and that young children should be included as soon as they're able to be included. I'm very excited that the hydroxychloroquine study that we're doing as part of TrialNet does include children down to the age of 3. So at least with that agent, we'll have some data in younger populations. But I do think that we have to be cautious about off-label use of any drug right now for prevention, and especially in younger kids. That we just have to have an eye on making sure that we are moving forward therapies that we think would be safe to give to our youngest children.
And in the same line of thought, le voy a preguntar a ella qué opina de que tenemos herramientas para hacer el diagnóstico, de que va a haber un debut en unos años después, pero no tenemos ningún tratamiento para ofrecerle. Linda, I also wanted to ask you about this situation we have now, that we are able to make the diagnosis that probably the child is going to have stage 3 type 1 diabetes in a couple of years. But we, in the clinical setting, we don't have any tool to offer for prevention. Here in Latin America, we don't have large trials to send our patients to be included. So even if we make the diagnosis, we don't know what to tell them about prevention or offer. What do you think about that? Because many people don't want to have to know if they will have an onset in a couple of years.
Yeah, I think it's really tricky. And if you don't have open trials, that definitely takes away one reason to do population-based screening. I do think that the data suggests that with screening and regular monitoring, you can reduce the risk of DKA in people at risk. But I think it's tricky if you're in a setting where there are no prevention trials. I think there are groups that are actively looking at ways to monitor these children, whether it's there are some guidelines that are, I didn't have time to put in the talk, but there's some like best practices, at least, that are the Juvenile Diabetes Research Foundation has put together as a set of guidance that suggests that regular clinic visits, regular monitoring for kids that are found to be antibody positive is important. But right now, those guidelines don't suggest any type of therapy. And I think it's early right now to really know what the best direction is. The other thing that we're struggling with, at least here in the US, where we do have some population-based screening approaches through JDRF, people can do finger sticks at home and send them in and get positive antibodies, is that we're realizing that the antibody assays that are being used are also different. And so the way that we look at progression to diabetes from TrialNet using a certain set of antibodies may be different than progression with other types of antibody tests. So although the data do suggest that if you're screened in the general population, your risk of diabetes is similar to if you're screened and found positive and you're a relative, those are using antibody assays that are different than what's available currently for general population screening, at least here in the US.
Thank you. Muchas gracias, doctora Meglo. Ahora voy a traducirlo, pero en el mismo sentido sobre prevención y sobre hermanos de diabéticos. ¿Cuál sería entonces, no existiendo la posibilidad de medir anticuerpos en la población general, la indicación para los hermanos de niños diabéticos, como, digamos, hacer glucometrías, con qué periodicidad? My question is regarding the family of the patients. When the parents ask about how they can screen their other sons to prevent or to have an earlier diagnosis and not in the ketoacidosis state. What would be your advice about that?
So guidelines currently, both the ISPAD and the American Diabetes Association guidelines do suggest that it is reasonable to screen relatives of people with type 1 diabetes for antibodies, but also going back to what Dr. Kodner asked earlier, is that it's predominantly in the context of being able to offer something in terms of a research study. I think if family members really want to be screened, they could use autoantibody screening, ideally with a panel of autoantibodies. And then after that, monitoring. I think that, all of our families who have access to it, I mean, unless somebody's solely on CGM, they should also still have a glucose meter at home. And so occasional glucose monitoring, watching for symptoms, I think some of that can be also very valid. But the other thing is really to make sure that our parents understand the likelihood of another child developing diabetes. So pre-pandemic, I used to be in charge of a diabetes camp for many, many years, and I worked with teens with diabetes in that camp. And I would always ask them, as part of a session I did at night, the counselors in training, so the 17, 18-year-olds, I would say, what do you think the odds are that your children will develop diabetes? And always the first answer I get is 50%, so 50. And I always tell them, no. The risk that your children will have diabetes is, between 3.57%, so a lot lower. So I think some of what we can do with our families too, if we don't have a place where we can offer close monitoring for the child, or where we can engage them in research, is to offer some reassurance that the likelihood is low, and then counsel them on the symptoms to watch for. I do think that once teplizumab gets FDA approval, and it looks like that might happen here in the United States, potentially as early 2022, then that will change kind of the way that we as endocrinologists and people that care for kids with diabetes need to think about this, because then there will be an effective therapy that hopefully will be available, although it's also not easy to deliver because it involves IV infusions and close monitoring, and it's a drug that's an immunosuppressive drug, which is tricky now during COVID. So I think the landscape is going to change, but we just need to see. But for now, I provide the data on the likelihood being relatively low. And then for me, I can offer screening because I have access to the research trials, but then think about whether you want to do antibody screening.
Yeah.
Thank you, Linda. Linda, there was two questions from the audience. The first one regarded the frequency of positive and autoantibodies in your population, because there is a high variability of positive antibodies here in Latin America.
Yeah, sorry, do you want me to do that one first?
No, go ahead.
I didn't mean to cut you off. So overall, it's about 5% of screened relatives will have antibodies, and that's higher than what you would expect, but it's because people tend to come as relatives if they have more than one family member. So when two people are diagnosed, more people are in a family, more people are keen to do it. I don't know that we know what the frequency of antibody positivity will be in the general population here in the U.S. I know that the rate of diagnosis of type 1 diabetes is felt to be about 4 in 1,000 in the general population. So you assume those people would have antibodies. Usually 85 to 90% of people at diagnosis have antibodies, but hopefully that answers that question.
No, I think the question meant to be about the people with recent diagnosis.
Oh, that's about 85 to 90%. Yeah, it's about 85, 90% here.
Okay, so maybe it has to do with the assays or
yeah, maybe
variability. And the other question was from Eduardo Cagliari, who was asking, what do you think of adding the genetic score to the diagnosis of new-onset patients to classify? I think he refers so we could clarify the endotype or the way of doing the diagnosis.
Yeah, I think genetic scores are really becoming interesting, and I actually hadn't thought about them, Eduardo, and like using them in that way. I think about them more in like, as we think about population screening and kind of getting to the people that we want to screen to see who's at risk, and using it as a way to cull down based upon genetics. But I think endotyping is going to be really important. So Johnny Ludvigsen is presenting some data now at ISPAD, and I've seen the data in other settings where he suggests that people that are, I think it's DR3, DR4, no, I want to say it's DQ8, DR2, DQ8. I'm not good with HLA, but that they are more, that they'll respond to GAD. So I think as we tailor therapies to certain endotypes of diabetes, I think that will be really critical to know more about the genetics as we have different therapies that are available and that we're studying.
Okay, Linda, thank you again for participating, giving us this beautiful talk.
Oh, yeah.
And getting us to know more about prevention of type 1 diabetes.
Oh, yeah. Thank you very much. Thanks for the invitation. Thank you for the invitation.
Thank you.
Yeah.
Bye. Hope to see you personally next year.
Oh, yeah, definitely.